This is Oral Rehab, Lecture 7, Part 1. Lecture 7 is in the general topic of issues in counseling and oral rehabilitation, remembering also that these issues, in my view, are equally applicable to persons in speech-language pathology. We just happen to be talking about our interactions in the oral rehab course with persons with hearing impairment or parents of children with hearing impairment. My view of looking at counseling is to look at it against a framework of grief and sorrow. And part of our success in being counselors with our clients and our patients is to acknowledge and to understand the process that they're going through, and so therefore that can help us to become that much more effective in terms of what we do with our with our clients rather. And not only that, but also to enhance their perceptions and give them a much more positive perception of their circumstance and of the services that they're receiving. I want to also just point out real quickly, Lecture 7 is not intended to be a how-to-do counseling. One of the outcomes of the movement for a national certification to doctoral programs in audiology is that those programs now typically incorporate a course in counseling. For speech-language pathologists, often, and here's a good example, Cal State Northridge has a graduate course that has as one of its principal features counseling. So it's material that you'll get. Those kinds of sort of graduate level courses in counseling deal much more with sort of theories of counseling and provide you with more sort of mechanical cookbook kinds of approaches to different kinds of counseling. So that all is material that you can look forward to at some point in your professional development. But here what I want to try to do is just provide you with an overview of some of the sort of concepts to give you a better understanding of what it is that our clients and patients are going through, again, to enhance our effectiveness in dealing with them. So the framework here that we're going to start off in is going to be against the framework of grief and sorrow. And you'll see why that's the case in a moment. So grief and sorrow, let's look at what these words mean. So grief, again, intense mental anguish, remorse, sorrow, or the like. Sorrow is defined as mental anguish, suffering because of injury or loss, and also sadness. So we can see that there's a tremendous relationship between these two words. In fact, grief is defined in the context of sorrow. Sorrow, in turn, it has this notion of injury or loss. Both of them share the word anguish. So there's a lot of relationship between these words. As we kind of put them into more of a practical kind of sense here, and I'll combine these two words because they're so closely aligned. We can say that grief and sorrow is this really complex emotional experience that's caused by, triggered, or keyed by some loss. That's really what's really operational for us. So it's, given the loss that one of our patients or a clients or a parent might experience, it's sort of the emotional consequences of that loss. Now, an important thing to note, certainly for this slide set and this course, and maybe beyond, is the idea that grief and sorrow is a natural and predictable reaction to loss. It's just as natural as any other aspect of any other predictable kind of behavior that we could anticipate. Grief and loss can be triggered by a lot of things, and some of them are much more obvious to us than others, but the sort of complex emotional experiences that you might have might be whatever sort of mild sadness that you have when you're returning from a holiday break back to your school duties, or as in many other people's cases in terms of their work lives also. And more profoundly, many of us will experience grief and sorrow due to the loss of the passing of a significant other or family member. Part of life is dealing with loss. Sort of our best, our character is tested when we have to deal with loss, and it's an inevitability of life. So we all will, go through some degree of grief and loss as we lose people that are important and loved ones in our lives. We can lose external objects, and not to trivialize this, but let me go to the next slide here real quickly, just to kind of point out to you. Here's a house that we owned in New Orleans. This is, the top one here is pre-Katrina. The bottom one here is post-Katrina. And in here you see a very, very pretty, you may not like the stylings of the furniture and so on, but a nice, pretty house nonetheless. And here's post-Katrina. Now here's what I want you to look at. Here's a line. Here's where the water line was. That meant that the house was 3 feet off the ground. Oh, I'm sorry. That's not the water line. Here's the water line. Doesn't matter. The house was 3 feet off the ground. That meant that the water got up to here. So that meant there was like 6 feet of water in the neighborhood. And so all of this stuff in through here is all mold and everything. The point is that this is a house that essentially had to be gutted, and it's a house essentially that we lost. We gave it up, so to speak. And so we lost a house. So that's a possibility as well. If I go back here to slide 4, loss of predictability of rewards. If you were progressing through a course or a sequence of things, and someone then just said changed up the requirements or whatever on you, you would go through some experience. You would have an experience that would be along this sort of grieving continuum. And more pertinently for us in this class, when we think about grief and sorrow, we're thinking about of some loss of the aspect of oneself or one child, some aspect of loss secondary to illness, or by having a medical diagnosis that has a sort of ominous or grave prognosis. So what we think about when we think about this grief and sorrow is really what we're thinking about as a grieving process, because what we're thinking about here is that we're talking about a couple things. We're talking about this as a complex, meaning multi-featured, multi-emotion progression that, again, as I said, involves many emotions. This grieving process, this notion of grief and sorrow, is fundamentally an attempt for a person to adjust and to cope and to adapt to their loss. So in that sense, as I said on the earlier slide, it's a natural and predictable process that humans go through, that people go through in a way to adjust and to cope with whatever their loss had been. Again, in many cases, the losses are going to be irretrievable. They're going to be irreplaceable. And that might amplify their sorrow, and that might again slow down their adjustment process, might prolong their adjustment process if they're ever able to adjust to it at all. Now, one of the models that is widely used to discuss this grieving process was originally written up by Elisabeth Kubler-Ross in the 1960s. And Kubler-Ross, I guess in modern times, we could say was really one of the first people involved, or at least this was a description, one of the first descriptions of what we might call hospice care in more contemporary times. And her work, and again, it's important to note this particular distinction. She was working with patients who had terminal diseases, who likely had terminal kind of cancers, whose prognosis was very poor, and who had just a fixed amount of time to live. And that's who sort of she was working with. And so in her sort of many years of working in this particular population, she described this in a model that sort of bears her name. And I'll go through those features of her model in a second. But a couple important points to note in the Kubler-Ross model in the grieving process is that she's going to lay out several stages. I could have just underlined it up here. So she's going to talk about stages in grieving, and so therefore progression through the stages is going to be normal and anticipated. However, the order and the actual progress is going to vary by individuals, meaning not all individuals will spend equal time at each stage. And so somebody might just kind of go through one stage very, very quickly, and therefore might spend an inordinate amount of time at other stages of this particular model. But it seems to hold pretty well. In my clinical experience, it seems to be a fairly apt and correct model. I'm going to draw a line here under line 5, and I'll tell you why. Kubler-Ross's model is based on these first 5, and sort of in order. Some of these we've already kind of talked about. If you remember back to the end of lecture slide set 1, I sort of did a prequel of these. You can go back there now and see that they're there. Denial. The person will just have a frank lack of acknowledgement of the condition. Secondly, anger. That the person is now going to be angry at the service delivery, at the person's at the condition, and some of this might be obviously irrationally and might be displaced at the practitioner. So, one of the features that you as a professional are going to have to deal with is that patients might be angry with you, and on the assumption that you're doing the correct thing, that you're providing the correct care, that you haven't done anything wrong, and therefore that the anger is appropriately placed. So on the presumption that you're doing everything right, patients are still going to be angry with you. And the mark of a professional is to not respond in kind with anger. You have to understand that the anger is really not directed at you. It's directed at their condition, and in fact is this part of this normal process, normal and typical process. Third stage in Kubler-Ross stage in grieving is bargaining. Bargaining is sort of the patient willing to do something lesser than what is really expected or what would be appropriate. I'll give you a tangible example here that might be appropriate for hearing. I might tell a person that based on your hearing loss, I think you would benefit with hearing aids, and the person would say, "Well, I'll tell you what, I'm not going to get the hearing aids, but let me take a speech reading class, or I'm not going to get the hearing aids, but I'll use those hints that you gave me on how to be a better communicator." So they're making a bargain. They're doing something that is sort of lesser, but they're switching up what was intended for them to do. Kubler-Ross observed that part of the stages in grieving also involved some level of depression, which is sort of a psychological state of an incapacity to sort of affect any kind of action at all. Finally, she observed that patients would get to a level of acceptance of their condition. Now, again, understanding that her patients were terminal disease patients, terminal cancer patients, most likely, then what we're talking about is then that's really the best that they could do, because with their acceptance now they would have a much better they would have a positive outcome. Essentially, they would be coming out of their depression. So their depression then they would be resolved, and they would now be sort of more positively disposed, and understanding that they've got only 3 months to live, but have a much better psychological mindset in their last days of life. Now, for us, simply acceptance is not enough. We need to do one more thing. We need to get our patients and the parents of our children with hearing impairment to take positive action. If I get somebody, and I counsel them and I get them to this step here, to this stage, where they say, "Yeah, Dr. Ivor, you're absolutely right. I know I have a hearing loss. I believe that I do. What you're telling me is true, but I'm not going to do anything about it." At that point, in a sense, I failed because I didn't get them to positive action. So acceptance alone, the simple progression through the stages for us, while it's normal and predictable, for us, we've, not just in AR, but in anything else where we're providing specific recommendations. So again, an analogy for you might be, well, okay, you just did an evaluation of a child's speech and/or language. You present those to the parents, and you say, "I think that your child would benefit from therapy, twice a week for the next quarter," or whatever the case may be. And they say, "No, we sort of like the way the kid sounds, or it sounds cute," or whatever their response is going to be. So in that sense, you failed because you didn't get them to take positive action. You didn't get them to sort of abide your professional recommendation. So movement to positive action is always going to be what we're basically interested in. So let's jump now to slide set number 2.